Welcome to my channel. In today's video, I will be showing you how to take a basic history on neurogenic bladder and bowels. Now, I work in the capacity of a rehabilitation physician in spinal cord injury. So when I created this list of questions, I do have a patient with spinal cord injury in mind. Nonetheless, you can refer to this list when you need to take a history on anyone who has neurogenic bladder or bowels. Let's first start with the neurogenic bladder. Now, your history does not have to be limited to just this list of questions, but if you go through this list, you're going to be able to gather a lot of information and it'll give you a really good starting point. In general, it's important to compare function before and after injury, or if you're seeing someone with a chronic neurogenic bladder, what you want to do is to find out whether there's been a change in that function. So let's go through the questions. Number 1, how many times a day do you empty your bladder? So it's not uncommon that a person may empty their bladder 4 to 6 times a day. Other than just checking their frequency during the daytime, also ask how many times they pass urine overnight. Certainly, if someone's passing urine very frequently overnight, it can really affect their quality of life. And as mentioned before, if you have a patient who's newly injured, what you'd like to do is to ask them, how is this function different from before the injury? Or if you're seeing a patient after you haven't reviewed them for a long time, you'd ask them these questions and say, now, is this different to your usual pattern? Moving on, question number 2. Can you feel when you need to empty your bladder? This is to gauge whether they have any sensation when their bladder is filling up. Question 3, does it feel urgent? Like, will you wet yourself if you do not get to the toilet immediately? Question 4, can you start passing urine once you're in the toilet, or do you have to wait or push or strain? Question 5, once you start, do you have a strong stream, or does it feel weak and dribbly, or does it start and stop? Question 6, once you finish, do you feel like there's urine left behind in your bladder? So this is to gauge whether the person might have some retention, and although they can feel like there's urine there, they're unable to evacuate it. Question 7, how often do you wet yourself? And if you did, would it be a large volume or a small volume? Just to clarify, this would not help you determine whether someone has a upper motor neuron bladder or a lower motor neuron bladder. And that's because someone with a really flaccid bladder may be experiencing a degree of overflow incontinence. So their bladder might be over-compliant and they end up filling up so full, but despite that, they're unable to void, and therefore they may still have only small volume incontinence. And someone with an upper motor neuron or hyperreflexic bladder, they may also only be incontinent of small volumes of urine, because that depends on a number of factors, including their bladder pressures and whether they also have detrusor sphincter dysnergia. Moving on, question 9, how do you manage your bladder? So certainly this is relevant for someone who's been injured for a longer time. So do they use pads, do they use catheters, or do they use nothing and they just get changed when they wet themselves? Question 10, when was your last ultrasound KUB? This is important for patients with spinal cord injury. It is standard that we perform annual ultrasound KUBs, and this is to survey for long-term complications of neurogenic bladder, including bladder trabeculations, hydronephrosis, hydroureters, whether the bladder wall is very thick, and the ultrasound KUB can also pick up some urinary tract stones. Question 11, when was your last urodynamic study? So in our unit, we ideally would like a person after spinal cord injury to have their first urodynamic study between 3 to 6 months of their injury. This is to establish what kind of bladder they have, whether they have an upper motor neuron bladder, a lower motor neuron bladder, a mixed bladder, and the goal of it is to make sure that the bladder is safe, meaning that the bladder pressures are not going to be so high that they cause retrograde reflux of urine into the kidneys and over a long period of time cause renal failure. Question 12, how many bladder infections do you have a year? So 3 bladder infections a year is 1 too many, and it may indicate that you need to look into things further. Why is this person having more frequent urinary tract infections? Is it their catheter technique? Are the catheters being changed frequently enough? So if they have a permanent catheter, it needs to be changed at least every 4 to 6 weeks. If someone has a catheter changed every 6 weeks, perhaps it needs to be reduced to every 4 weeks. But the person potentially have a urinary tract stone, that's a nidus of recurrent bladder infections. Question 13, what medications do you take for your bladder? Moving on to taking a basic history for the neurogenic bowel. So just like the bladder, compare the function before and after injury. Question number 1, how often do you open your bowels? For someone with an established spinal cord injury, what you'd hope is that they are at least attempting to open their bowels daily with an enema. For someone who is newly injured, it'll give you an idea of how frequently the person used to open their bowels. There's some people who don't open their bowels particularly frequently. Some patients only open their bowels every 4, 5, 6, or 7 days, and that may be their normal premorbid pattern. We usually still encourage these patients to try and open their bowels regularly with an enema after a spinal cord injury to prevent them becoming really constipated and them having to play catch up. Question 2, can you feel when you need to empty your bowels? So this is a question again, assessing sensation of the bowels. Question 3, does it feel urgent, like you need to rush to the toilet immediately? Question 4, how long does it take to empty your bowels? So sometimes, despite patients feeling particularly urgent, once they get themselves to the toilet, they may be sitting there for a long time because the bowels are just taking a long time to transit and pass. Question 5, can you stop yourself from passing wind? So this is assessing sphincter competence or sphincter function. Question 6, can you tell the difference between wind and feces? This is to assess how their anorectal sensation might be. And with question 5 and 6, sometimes patients are not sure, and that's okay. Usually what I'll ask them to do is, well, can you observe next time and let me know? Question 7, how often do you accidentally soil yourself? When you do, how do you manage it? So fecal incontinence is a very big deal. We ideally want to avoid any fecal incontinence at all because it can really affect someone's mental health and their ability to function in any manner, whether it be functioning at home or functioning in the community. And if a person is having very regular bowel accidents, say more frequently than once a month, it may signal to you that you need to gather a bit more information and do a bit more investigation to look for a cause. In terms of this question of how do they manage themselves if they accidentally soil themselves, so this is important because some patients will choose to sit in pads and go out, and the problem with that is that the stools can cause fecal burns and subsequently a pressure sore. And a pressure sore is something we really want to avoid. It again can really impact a person's life. So someone after a pressure sore may be subject to long-term bed rest between weeks to months. So ideally what you want to hear is when someone has had a bowel accident, they go and shower and get changed straight away. Moving on to question 8, what is your bowel management program? And hopefully if a patient has a spinal cord injury, they have some sort of bowel program. They ideally need to be trying to empty their bowels once a day, as I mentioned before. This can be performed by digital stimulation, a PR medication such as a suppository or an enema. And the idea is to stimulate the bowels to open at least once a day at a predictable time. This means that the bowel action is anticipated and it is cleaned up straight away to avoid pressure ulcers, as I mentioned before. And hopefully once the person has had a good bowel action once a day, in the morning it means that they're able to then carry on with their day without being too concerned that they're going to have a bowel accident. I'm speaking generally about morning bowel care, but certainly patients can choose to have a nighttime bowel regime as well. Question 9, have you had any bleeding from your bowels? And this is especially relevant for our patients who've got chronic spinal cord injury because they regularly use enemas and are also prone to constipation. It's important to check that they haven't experienced any injuries around the anus and that they're not experiencing any problematic hemorrhoids that need to be surgically addressed. So here is a list of questions. I hope you found this video helpful. If you have any questions, please leave it in the comment section. Certainly do subscribe. My intention is to be doing these bite-sized videos to hopefully promote your learning. Please like this video so that it can spread to more people. Share it with a friend who you think it may help. Thank you so much for watching.